Hi, everyone. Welcome to the Cleft Palate Craniofacial Journals podcast and video interview. I'm Pat Chibbaro, pediatric nurse practitioner here in New York. Happy to be your host. And I'm really happy to be able to present this paper. It's very near and dear to my heart. It actually, it's a wonderful study. It's about work that I actually, before I retired, was involved with. And I'm just so happy to see the work of this great team. Let me give you the name of this paper, which I believe is in the February Cleft Palate Craniofacial Journal special edition for young researchers. And I'm so happy to have this lovely young researcher, my friend and colleague, Meg Lico, here to talk about their paper, which is Back to the Bottle, Comparison of Palatoplasty Outcomes Before and After Systematic Changes to Postoperative Precaution Protocols. And all of the authors were at NYU Langone at the Hans-Jörg-Wyss Department of Plastic Surgery during this time, and some of them are in other places now. So it's Meg Lico, Jesus Rodrigo Diaz-Ciso, Sydney Gaynor, Leah Groisman, Mateo Laspro, Allison Diaz, Amanda Young, Liliana Camison-Bravo, and Roberto Flores. And I'm happy to have my good friend and colleague, Meg Lico, here to talk about the paper. Thanks, Meg.
Thanks for having me, Pat. We miss you here at NYU. And yes, everyone should know that Pat was really an integral part of this protocol change prior to retiring, and we miss her very dearly. So,
oh, you are so sweet. It's so funny. As I read this paper, I remember just the process, and anyone who's listening who takes care of kids who undergo cleft lip and palate repair, especially if you're involved in their pre and post-op care, for years and years, actually decades. And you mentioned in your paper, decades of looking at this issue of whether or not to restrict and how to restrict kids feeding and their mobilization after cleft lip and palate surgery. So I have many stories, and one of them I told Meg was the surgeon that I work with, who trained a lot of other surgeons who then went on and started their own teams or joined other teams who have followed his protocol. And he always used to say, when I wanted to maybe think about looking at what other teams do and can we modify restrictions, because I, as the nurse practitioner, was hearing from the families about the challenges of caring for their kids after surgery. Not so much, the suture line, not so much. It was about the fact that we would immobilize them and change their feeding. And so what he would say was, well, if it's not broken, don't fix it, because he had a great low fistula rate. And so I saw this. I was so happy when you were doing this, because it's something that, we really need to continue hammering on because of the difference in protocols all around the country. So I wonder, my first question for you and your group is, why did you decide to do this study? Why take this on?
That's a great question. Thanks again for having me. So we decided to do this based off of essentially my push to do so, because of a really great panel that I actually saw at ACPA. I forget if it was 2022 or 2023, I'll be honest, but at one of the panels, there was a wonderful talk on postoperative feeding care and also just feeding care in general. And they had members from a ton of different disciplines, which I really appreciated. It was my favorite talk that year. And there was an SLP, there was an NP, there was a psychologist, but one of the most moving parts of the talk was that the psychologist was also a mom of a child who had had a cleft. And she was explaining that it's very easy for providers to stand up and make XYZ recommendations, but she knows firsthand what it feels like as a parent to be in that postoperative period, right when they're talking to you, Pat, or other NPs about their journey in that week. And she had said it was one of the worst weeks of her life, and it was so terrible to have to take the bottle away from her child and, restrict him in such a way that really made it an unpleasant experience and really affected her psychologically. And that's somebody who's a provider in the field who understands the need to preserve the surgical site. But also as a family member, I don't think we as providers always understand that. So that got me really thinking about what research is there out there, because I knew that at NYU, when I had joined, They had just started allowing a couple of years prior kids to go back to the bottle immediately after. And so I was like, why are people still doing this? So I went on a big literature search, and there was a lot of research to support going back to the bottle or breast after lip repair, but not so much after palate repair. I think I found, and I cited one study out of Japan that was a similar study to ours that did support it. But then there was also an ACPA study that had been done, a CPCJ journal study that had been done recently in 2023 that they surveyed a bunch of providers across the US, and so many of them were still not allowing the child to go back to the bottle. And this is after that one Japan study was out. So I was like, you know what, there needs to be more data here and more support here. And so I went to my surgeon specifically about the feeding, and he thought it was a great idea. And we have a lot of that information in the charts, obviously through our Epic interspace or hyperspace. And he actually had the idea to tack on the arm immobilizers as well. And so we decided to join forces, surgery and feeding team, including NP, dietitian, and myself. And then we basically got to work. So that was really the talk that inspired it all.
So when you decided to do this study, what just maybe walk us through what exactly what you looked at, and what and what you found, and also did you find anything that you were surprised to find? I always love to ask that question, because sometimes you think you really know what you're going to find, and you don't.
I actually was the most surprised about my literature review. I was surprised at how little research had been done in this issue, and that people felt so strongly about it, but there was limited data. My hypothesis coming into the study was that we would not see a difference between two groups. So basically what we did is we looked at patients prior to patients who received palatoplasty prior to the 2018 calendar year, and then patients who received it 2019 and beyond from the same surgeon, because in that 2018 calendar year is when you, Pat, and the rest of the team worked to switch and transition everything over to make sure that families knew they could go back to the bottle versus having to use something like a syringe feed or those specialty, what we call like bird feeder bottles that used to be given out. And also the switch to hand socks. So we did a big deep dive as a retrospective study into charts, and we kind of extrapolated all of the surgical outcomes and data that we had available to us. And so we ended up with 84 patients who underwent primary palatoplasty and met all of our inclusion criteria, and essentially excluded anyone in the 2018 calendar year. And we looked at, in terms of variables, the postoperative wound complications. So did they have any kind of fistula or dehiscence that didn't resolve through secondary intention? How long did they stay in the hospital? So any complications from that standpoint, maybe with feeding, if there was a difficulty feeding, sometimes they keep a baby longer, and then 30-day readmission rate. And then we had one of our wonderful co-authors do some of the stats. And so essentially, after looking at statistical significance, we didn't find any differences between any of the complication rates for wound complication, no statistically significant differences for length of stay or readmission. And there was a pretty even split between the sex, age of surgery, like VO classification, repair technique. It was fairly evenly spaced out. So nothing too heavy on either side, nothing to reach statistical significance. And so basically my hypothesis was confirmed in that, for our team at least, I mean, I can't speak to the entire, nation across different surgeons, but we found that we could relax the postoperative protocols to allow for immediate bottle feedings. And then the hope, obviously, is that we will inspire others to do their own research at their own center, and then maybe eventually make the switch to make this an easier journey for families. So yeah, nothing surprising except for the fact I was so surprised that surgeons were still doing this without like research and kind of support behind it.
So do you think that, so I was looking at, I was just trying to refresh on your paper, the percentage from that survey. So it's a very large number of centers that are still using arm restraints. And the question is, why? So is it because one, as I was stating, it's, surgeons are taught by surgeons, and, and I think one of the things that I just always remember is they're so scared about the development of the fistula, and they're very concerned about that. And it's not that they don't care about the child, but I think that that is their motivation, and that when they see that they have good results in terms of fistula, they want to stay with what they feel works. And yes, it's inconvenient, but
Right.
we, as the ones that are day to day taking care of these kids, we know. I remember one time a mom called me and her baby was screaming, screaming. And she put me on the phone and she said, "No, I'm not taking the phone away. You cannot hang up on me." And this baby literally was screaming for like 5 minutes in a row. And, one of the things I always worried about is the pressure that these kids put on their palate repair by all of that screaming. And there's lots of it. And this mom just said, this, and she said, "I'm going to remove these, restraints." And so I think, for the surgeons, it comes from them wanting the best result, but on the other hand, it's looking at the whole picture. And then, as you said, having the data. And so do you think if there were more studies from more centers about their particular results by, lessening the restrictions or not having, there are some teams that don't use them at all. And I think you mentioned in the UK, isn't it in the UK? I think one of the studies where they're not using them, is that right?
I think Japan, for the bottles. I think in the UK there was a kind of like almost a letter to the editor of sorts, where one of the surgeons there had said, "We barely use them here in the UK.
Mhm.
Why is America still using them?" So it was more of a commentary. I don't have specific data from the UK, but that's essentially what a response was. And also, to your point about the wound healing, one of the best things I learned from you, Pat, and our dietitian Deb, is that nutrition is a really important part of wound healing. And so if a baby is no longer taking their volumes and eating the way that they were prior to baseline, or at least as close to as possible, despite the pain they're in, if
Mhm.
they're taking smaller volumes from a syringe, that's not really going to help the wound healing either. So while it is an important, not having a fistula is really important, nutrition is also important for the wound healing as well. So by taking that away, I don't really know, are we doing more harm than good in that sense?
Yeah,
Um, and
great.
then, yeah, exactly. Same with the arm immobilizers. I think that's more of a psychological thing of, families not being able to see their child move their arms and hands from a speech pathology standpoint, fine motor skills, for self-feeding. I'm sure OTs would hopefully feel the same way, is restricted in that period. And so I think the hand socks do a great job of still protecting, any fingernails or fingers kind of getting in there, but allows them to still use their arms in that critical developmental period.
Yeah. So do you have any thoughts, and I've wondered this over all these years, is what else can we, as the providers of this very one-on-one pre and post-op care, when you look at all these teams, there's over 200 teams in the country, and any one of them is doing, anything, other than what another team is doing. And the question is, and I think it's been attempted, how can we put information together? And you've seen, things here and there. Any thoughts, about what
Yeah.
else could be done from a multi-center, maybe a multi-center type approach to get more data to try to then maybe help teams, make some more decisions about possibly being more comfortable with lifting restrictions?
That's a great question. I think there's a few things, that you mentioned in that. Number one being we need more cross-departmental or interdisciplinary studies across multiple centers in the US. I think Cornet is one of the big speech ones that's trying to accomplish that. As of recent, I've heard some great things coming out of that organization, which is a multi-site study. I do think a lot of it right now is very focused on speech. So I'm hoping that they'll be able to move to post-operative care and feeding as well as Cornet expands. And I know that a lot of different centers are in Cornet, so I give credit to all of them for all of the work they're doing. But I also think at the end of the day, the biggest thing is, are people willing to make changes? Because I when I went to ACPA the following year and presented this as an oral presentation before it came out in print, and we had the data already, but we just hadn't written the manuscript up. I had it accepted as an oral presentation, and I'll never forget that later that day, I had a surgeon I never met come up to me and say, I am changing my protocols because of that study. He said, I've always thought it was very strange, but when I came in as a resident and then eventually as a surgical fellow and again a surgeon, I was taught that's the way it's always been done. Don't change it, don't change it. And he's like, I always thought it was weird, but I just stuck with the status quo. He's like, and I used to hear complaints from parents that he was on a smaller team. So he said he did a lot more of the post-ops because he didn't have such great NP support like we do at NYU. And so he's like, I just never understood it. And it just took these types of studies to push me to really examine this. And I think another piece, and the third piece I was thinking about when you asked that question, is like, are we checking ourselves? Are we auditing ourselves to make sure that as a team, we're doing everything we can for these families and making sure that we're up to date with the latest research? And if you're not sure, like, for example, this is a small scale study. I mean, I wish we had a larger data set, but because we only, implemented everything in 2018, we only have really a few years, and COVID obviously changed things as well. So we only had a few years from the same surgeon to go off of. And so are we, if you're not sure about the literature and you're just like, well, that's a great study out of NYU, but, I don't know how that much that'll translate to our center where we have 10 surgeons. Okay, then do your own study. Like, I highly recommend that everyone tries to replicate this, whether or not it's published, just from an auditing standpoint, and see, what the changes are. And I'm curious to see how that plays out, I guess, in the next few years as these things like Cornet, and I know there's a big one in Europe. I think you know about it, Pat. There's a big cleft collective in Europe and the UK. I'm forgetting the name, but they're coming out with a lot of large scale research as well. And so I think we need to do more of that collaboration and then self audits on our own teams.
No, I think those are great suggestions. I wanted to ask you there in your discussion, one of the things that you mentioned, or actually in the conclusion, that something that needs to be looked at is, I'm going to actually read what you wrote. Research involving the role of utensil use and infant self-feeding in the post-op palatoplasty period to further reduce caregiver burden may be beneficial. So, and this is something I know before I retired, that the whole baby-led weaning, thing was happening. And it did worry me a bit because I felt that by letting the kids be doing the baby-led weaning, feeding before the palate surgery, that's another thing that we're taking away from them. And how would that impact them? So I wonder you mentioned that in your discussion. So what are you thinking about that in terms of the kids you're dealing with?
Yeah, that's a great point. And I remember us having a lot of discussions about this when I first joined, because I'm coming in like, oh, baby self-feeding and oral motor skill development. And you're like, whoa. There's a surgery coming up. And I'm like, wait, what? And it's like a seesaw, right? So like the more that you promote their oral motor skills for chewing and tongue lateralization and things like that, the better. But then also, then you have to take it away when they have their palate repair. And then how much is that going to burden the families? And it's a good point. We don't want them sticking in some kind of hard, crunchy material, like I know a chicken wing's a big popular one in baby-led weaning, and then them hitting something. So obviously there's more conversation to be had about that. And I don't think there's a perfect solution. I think both points are valid, and it's just a matter of figuring out how we're going to go about it. My personal next steps, because that is something that I've been thinking about since doing this bottle study, is to take a look at, are there any foods currently out there that dissolve into a puree? Because we know that most babies are either on bottle and thin liquids only, or bottle, thin liquids, and purees. And so there's a great company called Savory's that is like one of the only clinically proven dissolvable melts that kind of turn into a puree. And for those of you listening who know about the IDSI, the IDDSI level chart, that really moves into a puree level on the IDSI. And so in a way, they can almost guarantee that it's a puree by the time that it hits saliva. And so would that allow a child in the postoperative period, for example, to still enjoy some dissolvable puffs, and also make it easier for families to be able to relax a little bit, but also preserve the surgical healing. So that's the next step. We don't have the results yet. We're still enrolling patients, but we are doing caregiver surveys, which we think are really important to hear from them. And we're looking at wound complications, making sure that this might be safe to consume, or for infants to self-feed, to work on those skills without causing some kind of unfortunate fistula or wound complication between the groups. So hopefully we'll have that in the next 2 years.
All right, looking forward to that. Well, before we wrap this up, I wanted to, at first I wanted to ask you, is there anything else about the paper that we didn't talk about that you wanted to highlight? Anything that that you think is important?
I think we covered a big part of it. I think, our limitations are certainly there. I highly recommend everyone kind of read those. It did exclude patients with a genetic syndrome. I would love to in the future potentially do more studies, or have someone conduct studies, including those kiddos. The reason we excluded them is because a lot of those kids were tube fed in the first place. And so we felt like it might change the results, especially if they were only taking a little bit of the bottle, but
Right.
mainly tube fed. So that's why we decided to do that. But I do think they're an important population. And other than that, just thanking all my, co-authors who did all of the hard work and heavy lifting in addition to myself.
So, no, it was great work. And I think, we just need to, and hopefully when we go to ACPA in May, and we can, talk about this with other teams and, other people involved with the post-op care, and, and get others to, to look at their own practice, and, and put this together. And the more we can publish and talk to each other about it, and talk, and, and again, talking with the surgeons who we understand, where they're coming from, but I think you're right. The more, data that we can see and show to them and share with them, the better. And I wonder, one last question for you is, as a relatively new researcher, although you've done quite a bit in the short time since you got out of school, and so I'm so proud of you, Meg. You've done amazing, amazing work. What suggestions might you have for some others in this world of cleft and craniofacial care that might want to study something, but it's overwhelming, and you know that from when you first started doing research, and what do I study and how do I do it? Any thoughts for them?
Yeah, I think it's really hard, especially when you're also doing clinical work, to be able to commit to doing research on this level. And so I think finding the right mentors. So having you, Pat, so involved in ACPA. I also reached out to a few SLPs in the field to talk to, who've published and are clinicians at the same time, talk about like, how do you manage this time wise? And I won't lie to you and say that I've had a lot of time on my hands, free time, with this paper and with a few other papers we have coming out soon. But overall, having that support system and seeing, okay, where do I need to like delegate, or what do I need to offload, right? Like at NYU, we started a really great program where I now have a fellow once a week who is a graduate student in speech, who comes and does a lot of the smaller tasks, like data extrapolation, for example, management of like IRB regulatory documents. That has been really helpful from a time standpoint. And then having that departmental support. So being able to go to your department, to your surgeons, to your admin, and saying, hey, I really want to do this, but I need time. Because I do think that if you try and have a full patient caseload, you could have some really good ideas, because I think we're the ones on the front line seeing the real problems at hands, like this, for example. But we do need some time to be able to accomplish this. So having time to go to ACPA and see these talks, like learn from other researchers in the field at ACPA, I think are so huge. And to be honest, that's really what led to the success, because I definitely would not have been able to do this alone by myself. I wouldn't have had the time. I wouldn't have had the funding, the ability, so I think having that team support is really, really important. And then on a larger scale, the ACPA support.
No, I couldn't agree with you more. And, I'm so glad that you were able to have a fellow. I mean, certainly it's something that I wish that I had had, in all the years that I was there, because I think it would have made me be able to do a lot more.
And it holds me accountable too. So like when my fellow's ready, okay, I did what you asked. I'm like, oh wow, I really have to commit to this. And because I think if you're by yourself, you're like, oh yeah, I'll do this when I have free time. And then of course, anyone who works in this field knows that there's never any free time.
Exactly.
So,
Exactly. Well, thank you so much. Let me read this paper to everyone again. And again, it's in the February special edition for young researchers in the Cleft Palate Craniofacial Journal. It is Back to the Bottle: Comparison of Palatoplasty Outcomes Before and After Systematic Changes to Postoperative Precaution Protocols. And this came out of the Hans-Georg Wyss Department of Plastic Surgery at NYU. And the authors, again, Meg Lico, Jesus Rodrigo Diaz-Ciso, Sydney Gaynor, Leah Groisman, Mateo Laspro, Allison Diaz, Amanda Young, Liliana Camison Bravo, and Roberto Flores. And I am so grateful, Meg, for you doing this work, and again, really proud of the work that you've done. And I know there's much more to come. So thank you so much. I know how busy you are.
Thank you, Pat, for having me. I appreciate it.
All right, take care. I'll see you in Palm Springs.